having a conversation today about SHA versus the private hospitals. We do have the chairperson of Rural and Urban Private Hospitals Association of Kenya, that is RUPHA, Dr. Brian Lishenga. Daktari, karibu tena sana to Radio Generation.
Thank you, Mbuvi.
Right. Yesterday I was just, it was yesterday, no? Was it Monday? Monday, yes. We were having a conversation with...
Monday is not yesterday anymore.
No, yeah, I know.
For him.
Sometimes, days are a phase, eh?
And yesterday doesn't literally mean the day before today. It means
it could have been any day before today.
Yes, yesterday.
Sometime this week.
Yes.
But anyway, so we're having a conversation with the CEO of KMPDC and a conversation around RUPHA just
for having me. So RUPHA stands for Rural and Urban Private Hospitals Association of Kenya. We are an association of hospitals, medical centers, diagnostic centers, clinics, name them, that are privately owned across the country. We have been in existence since 2019, registered under the Societies Act. We have a right to associate.
Yes.
It's constitutional. The right to associate is constitutional.
Yes.
So we have grown over the last 6 years from the initial group of 12 healthcare facilities which founded to now over 720 healthcare facilities across the country, with a significant representation in many of our larger cities. Initially, by the way, we were simply the Rural Private Hospitals Association.
Yes.
But Kenya is urbanizing. I'm sure you're aware. Our towns are growing. Places that 5 years ago were considered rural are no longer rural. When we started out, Nakuru was a town. Now Nakuru is a city.
Right.
Eldoret is a city as well. So these things, our members themselves demanded that we give the word urban,
right.
And that happened in 2023. So what we do, we have 4 pillars. One of them is advocacy, which we have been most known of recently. Advocacy, which is talking to the executive, the legislature, stakeholders about issues that affect policy issues, where you have policy change. Number 2, we do capacity building for our members. We talk about issues like quality of care, financial management, standards, and things like that. Number 3, we do aggregation for equipment and drugs and consumables. So we try and leverage economies of scale. Once you have, a good number of people in a sector, it is possible that you can come together and buy goods together. It's also part of our contribution to UHC, because if we can buy commodities in bulk, we can then lower costs and therefore transfer those benefits to the health ecosystem. The final pillar is partnership. We build a lot of partnerships. So we try and bring, for example, financial institutions, insurances, people in IT. We bring all these people who are outside of healthcare.
Yes.
We bring them into the healthcare space and introduce them to hospitals. So we try and build those cross linkages and partnerships. So there's a lot more going on. And Urban Private Hospital Association. Advocacy is one of those that we are doing because of there's been a lot of talk about healthcare in this country for the last 2 to 3 years, especially because of this government's agenda of reforming healthcare. So policy has been a big issue, and that's why our advocacy pillar has stood out a lot more. But the other pillars are still ongoing, and that's what we do.
Okay. Because when I was just checking up, looking up and reading about RUPHA, I also saw there's a Kenya Association of Private Hospitals. Then there's the Kenya Association of Private. There are some 3 private hospitals bodies.
So they are. So that's a good point, movie.
Right.
And just remember, I started by saying right to associate.
Yes.
That's I don't know how many political parties there are in Kenya.
Oh, there are very many.
There are many. There's one which calls themselves Baba na Mama these days, the big ones. Okay, but basically there are 5 major hospital associations in this country.
All right.
Three of them are faith-based, and 2 of them are private. Okay. So the 3 faith-based are the Christian Hospital Association of Kenya, which represents faith-based Protestant owned facilities.
Right.
A good example is, for example, PCA, Tumutumu, Kijabe. Those ones would be under CHAC. Tenwek, for example. Those ones would be under the Christian Hospital Association of Kenya. And then there's a Kenya Conference of Catholic Bishops Health Department, which then represents KCCB Health.
Catholic hospitals now.
Catholic hospitals. And then there's SUPKEM for the Islamic based. There are other religious organizations, but they are not as cohesive as these 3. And then on the private sector side, you have the Kenya Association of Private Hospitals, CAF, and then you have the Rural and Urban Private Hospital Association. Now, CAF is a much older organization. I think they're over 25 years old. And their genesis was largely urban center. They came into being from the big hospitals that you know about, the Aga Khans, the Avenues, the Nairobi hospitals, those ones. And what was missing for many years was the voice of smaller private hospitals, small to medium enterprises in rural communities, in semi-urban communities, or even like here in Nairobi, private hospitals in places like Kibra, Kawangware, Umoja, their voices were not there. And those hospitals largely are in RUPHA.
So those Okay.
Yeah. Now, the reason for that is that they have, sometimes we convert of a resident of Kibra might not be the same as the healthcare needs of a resident in Karen or Mudaiga, for example. And when you are talking about health insurance in Kibra, you talk a different language than when you're talking a certain other part of the... sometimes...
Why is it different?
It is different because of how our healthcare system has evolved. Eventually, ultimately, when we get to the promised land, we'll get to the promised land where wanyama wote wako sawa.
There are none that are more equal than others.
Yes, no animal is more wengine wako sawa kushinda wengine. When we get there, and in fact, since, for example, with the Kenya Association of Private Hospitals, we maintain very close communications, actually with all these associations, even with CHAC, whoever. We're always talking with their leadership. But let me just specifically put private sector. Once we get to a point where there is a singular health system that is not determined by your status in society or your economic capacity, which is really the vision of UHC. Once we get to that point where it doesn't matter whether you are poor or rich, you can access the same healthcare, then you don't need different voices to speak for different people. So it's our aspiration. We think that when Kenya reaches there, we will also arrive there with them. But right now, we do not want any segment of the society to be muted. We want all those voices to be on the table.
Actually, there's something I'd like you to expand on a little bit. When you talk about the healthcare needs of individuals who live in a certain geographical area and those who live in another, what is it that differentiates the health needs?
Okay. So very good question, Siti. Let me put it this way. We have what we call social determinants of health.
Yes.
The social determinants of health, these are the downstream factors that determine the health, the well-being of people. These social determinants of health are determined by income level, living conditions, demographics, lifestyle. Now, because in Kenya, we have a huge income gap. In fact, Kenya is one of the most interesting countries in Africa where you have super rich people and then you have just people who are extremely poor. You have a small but was growing middle class. It was growing. It has suffered a lot of assaults recently. But you have this huge gap. And if you look even at around Nairobi, any high class estate, in the immediate vicinity you have a slum.
Yeah.
People usually, people argue that those are the workers who provide labor here. So, for example, if you have Mudaiga, you have a slum nearby, Madare. Yes, okay, sawa. Let me just say Madare. And then, you have them.
So, Kilimani, you have Kibera.
Yes. So, when you go to Madare, the way, even the housing itself, the sewerage system, the water system, the road infrastructure, the proximity to healthcare facilities, the disposable income for, when we talk about healthcare insurance, by the way, or healthcare cover, is usually determined by disposable income. And that is one of the mistakes that we did with the SHA rollout, because we looked at expenditure. We do not look at disposable income. So a household that makes 5K or, has very little ceiling after they have, bought unga, mafuta, just what you need for basic survival. It is what remains that can be used on, say, healthcare or school fees.
So you're saying that wasn't captured in the SHA?
No, the methodology used was wrong, and we advise that it was wrong. It was truly academic, and not steeped, rooted in reality. So the point is, if you are in Madare, just because of the ecology, the living conditions, the disease conditions that you are likely to experience are very different from your neighbor who lives in Mudaiga. Okay, let me give you an example. Tuberculosis, is more likely to be happening in Madare than it is likely to be happening in Mudaiga.
True.
Just because you have people sharing one-room houses. If one person catches a cough, that's it. Everybody's going to catch a cough. Diarrhea, for example, cholera, dysentery, all these things. So you have these differences. And even people who come up, if you have diabetes and you are in Kibra, for example, your access to medication, compliance to treatment, all those things will, telemedicine. Who can you? If I am well off, I can have a consultation on my phone. My doctor calls me, as a private doctor calls me, says, CT, when was the last time you took your medication? Have you checked your blood sugar this morning? You get such personalized care. When you're in a different setting, those are luxuries that you don't have.
Well, Dr. I want to take you back to that whole SHA issue, because you're saying, or rather, I want to ascertain that this is what you're saying. The way they did the mean testing, or how they formulated the mean testing, there was an issue with that, or what are you alluding to?
This is what I'm implying.
Yeah.
So, first of all, they have been accused, and I read a paper recently on the communication failures of the Kenya Kwanza administration. Some university postgraduates did a very good paper. I just looked at what the communication failures were. And one of the criticisms around SHA, they were looking at two main issues, housing levy and SHA. And on SHA, one of the criticisms was technocratic language. And I agree. One of the SHA reform, if you read the documents around it, they're not designed for public consumption. Even for just a regular guy with a degree, they are tough documents to read because the language is quite technocratic and quite niche. It's niche language. You have to be in the sector or somewhere in the vicinity to know what these guys are talking about. So up to this day, we have not gotten a translation for common people as to what means testing is. When you can, I don't know how you go to the village. How do you go to the village and explain to your grandmother proxy means testing? See, that's very technical language. But that being as it may, so the technocratic language was a problem. But it was a symptom of a deeper issue. The deeper issue was the approach was highly academic. And nothing wrong with our colleagues, very learned behind the presidential advisors and such things. But proxy means testing, wherever what it is used for movie. Proxy means testing is used to let me even give you the correct why the people who developed the model. It is used for excluding non-poor households.
That is its purpose.
Yeah, the design is not for inclusion of poor households. The design of proxy means testing is to exclude non-poor households when you are designing social programs.
And you're saying
so,
that,
in other words,
yes,
when you deploy the tool, the way it was designed, your intention is to make sure that you super select, the tool super selects for people who are well off. Okay, let me put it this way.
Yeah.
At the end of proxy means testing is to minimize government exposure on expenditure on public goods.
So what you're saying, Dr.
So if you have 10 people here, what proxy means testing does, it is biased towards overestimating your well-being. That's what I'm trying to say.
Let's put it in simple terms.
Yes.
It tries to determine if you're poor enough to get help.
Yeah. And for it to do that, it must exclude that you are well off. So in other words, it is looking for any evidence that you are well off.
And the indicators that prove that you are well off or not.
Yes.
Now, again, that's where the problem would be. You see, when Dr. Ari talks about, and he gives a good example of what a family earns and the concept of a disposable income.
Right.
If the income is 5,000, you'll actually find they're spending 7. So they're always in debt.
Permanently.
And that's just to meet the basic needs.
Yeah.
Yes.
Now, what proxy means testing will do, it might consider the guy who can access the extra 2K
yes.
Credit as more well off than the guy who even chooses not to take the DNI.
And yet this guy is actually not better off
than the other. The guy who is fuliza, the 2K extra might actually be more distressed.
So
than the other person, because that person has found a way of living within the means of the 5. This other fellow has not. So this fellow who goes beyond his actually means is actually in a bigger problem than the other one.
But the tool is likely to consider him as well
being
off.
better off.
So, Doc, what I'm asking then, because now that you've explained it the way you have, are you saying that the people who designed this knew this and they did it deliberately?
Give me a position. Let me say it. When someone tells you it was theoretical,
right,
what they're in effect telling you is that particular system was not piloted to see if it flashes out what it is you intended it to serve.
But I want to go back to something Daktari said. He said that we know that people who came up with this particular system and this formula ni watu ambao wamesoma, ni watu ambao wanajua. These are experts in their fields. Yes? So by the time they were doing this, whether they intended to pilot it or not, they knew the outcome and they knew this is what, because you can always project.
No, when you're theoretical, you assume, it's actually an assumption. Remember, what we're talking about, even if there is an algorithm, the question I would ask is, has it ever been tested on a population such as ours?
Okay.
Because it has worked elsewhere. We know it has worked elsewhere. But has it ever been tested? For instance, if I were to ask you, according to Kenya National Bureau of Statistics,
yes,
what is the amount of money they consider is important for a person living in an urban setting to earn the bare minimum?
I would suggest, because they're the same people who advised the government on and the president.
No, they've actually documented the figure.
Yeah.
Yes.
On minimum wage. I think it was said to be about what, 15 Gs?
No, it's not wage. It is what you're able to survive on.
Okay.
It's a universal thought that very many countries have had, and it's what they base this support they give people who are out of work.
Yeah.
In Kenya, it is 6,000.
So you asked just to answer, to add to what City is saying, and is right. There's also another factor that helps to answer your question of very educated people doing what they did.
Yes.
And that is political dynamics. Okay, so the politics can get into the way of education very, very seriously, and you have seen it. Once politics is inserted, even in the heads of PhD holders, you seem to, the education seems to fly out. So, when there was a debate, because the whole thing was about how do we pay for healthcare, so it was financing. There are two schools of thought. There were two schools of thought. We go for a tax-based system, or we go for a contributory system. Okay. most professionals in the sector say were in favor of a tax-based system, where we use general taxation. And in fact, a lot of them were proposing what we call earmark tax. Earmark tax would be like, for example, we do railway development levy, fuel levy. I have seen criticisms. Some Kenyans consider consumption tax, because these are consumption taxes, to be regressive. In other words, why are we be tax? Even the Gen Z revolts were about taxation, But the argument is very simple. Why a lot of professionals supported general taxation, for example, VAT is a form of general tax, is consumption taxes, truly speaking, disproportionately target the poorest or the most vulnerable or those with the lowest income. What I mean is this. Regardless of your income, they usually, I'm saying usually, caveat.
Yes.
When you buy unga or when you buy, a bag of rice, generally the prices are comparable regardless of where you're buying. Generally, it would be a difference 2-3 shillings. But a person earning 10,000 a month and a person earning 100,000, 150,000 a month, when they go to a shop, they will be exposed to the same prices for unga and for bread, for milk, essentially. But as a proportion of their income, the guy at 10K is spending more on VAT as a proportion of their income than the guy at 100,000. You get the argument?
Okay.
So consumption tax is considered regressive because it hits those with lower incomes harder than those with higher incomes for the same set of commodities. It only starts to change when people start buying luxury goods. Like, if you're buying your shoe at a certain place, then it changes. But the counter argument for that, and this is where Kenya Kwanza administration took a different route, where they went to proxy means testing. The counter argument for that is that if managed well, consumption tax is more beneficial to the people with lower income than the guys who are on higher income. In other words, if we had to put a levy just 1% extra on VAT and we called it an earmark tax for health, of course we will have to make sure Treasury has good manners, because the National Treasury usually has very bad manners. When they receive money, they consider all this money is theirs and they do as they wish. So and the reason why they have opposed earmark tax is because it ties their hand. Once that money gets there, Treasury cannot use it for anything else.
It has to be for the purpose.
For the specific legal purpose.
Okay.
And Treasury has usually opposed earmark tax because they they just want to spend the way they want to spend. But once you have that 1% on VAT and you put it in a pool called the health levy, isn't it? Although the poorer Kenyans would be contributing a higher proportion of their income, when public facilities start to work from that levy, when they find the drugs in their nearest health center, they have a more benefit than the guy who earns 1 million shillings. You know why? Because the guy who earns 1 million shillings, although he is paying less VAT proportionately, has options. Like he doesn't need the public facility, he doesn't need the health center, he can take a flight to South Africa and get his health care. So they should have stuck to their guns early and done an earmark tax for healthcare, and then told Kenyans, yes, we've increased VAT by the way we calculated a VAT increase of 0.5% earmarked for healthcare would have been enough to fund. Really? Yes, just as small as 0.5% would have been enough to fund all these things. Whatever we are asking Kenyans.
Yes.
So I mean, even if we had pushed, so our VAT is 16%.
Yes.
So even if we had pushed it to 17%, but just said this extra percentage point is strictly for healthcare,
it was going to be more than enough.
It could have worked, And then we tell Kenyans, we don't tell Kenyans that we are coming to your house to do proxy means testing. No, we told Kenyans we have taxed you, but just walk to the hospital and walk out.
Daktari,
you've already paid.
Daktari. Is this a proposal that you actually proposed to Gava and
very seriously, very very seriously?
Waliwaambia nini venye mliwaambia?
Walisema hatujasoma vizuri. Kuna watu wamesoma zaidi.
Paul, consider for instance, once upon a time we used to have toll booths along highways where as you passed certain places you'd pay. And someone came up with a very clever idea and said, but why are we bothering with all these structures? All these vehicles use fuel. Why don't we?
Weke hiyo pesa kwa fuel.
Yes, I mean, smooth sailing, because you don't.
Yeah.
Once you fuel it doesn't matter whether you're using kerosene for fuel, you're using whatever it is that you're using.
The point is you've paid that tax.
You are going to pay it.
Even if you fuel for 50 bob,
it doesn't matter, you're going
or
to pay
50,000.
And we then have money for repairs of roads. And we see signs. This road has been maintained. It isn't that we do not know. That's really the point I'm getting at.
And that's another example of the earmark tax.
That is a very good example.
Yes.
You go around the country and you see a city saying, signboards, this road is maintained or built by the fuel
levy. But more importantly, when you understand that particular principle, okay, you realize that there's a lot more you can do with it than even just providing healthcare.
Yeah.
When you are jump-starting a system from the very beginning, it'll cost more, because there are things you need to put in place.
Yeah.
After a while, it will not cost what it cost at the beginning.
No.
Not really. And remember, the more people get into the workforce, the more money you actually earn, or the more money you actually make. Now, there's a concept that the government has recently sort of like gotten themselves into. It's called securitization. When you have that amount of money and you can see that this money always comes in, that is money that you can actually use as security to borrow to do other things with. So there are very many things you can do with it. You know why? It is in a system, you know how it's going to come in, and you know even the amount, and you know you can even estimate by as to how much it will increase by. These are things that you cannot tell me was not known to the people who are crafting these things.
Yeah.
It was very well known to them. They just chose a different route.
Why, Daktari? Why? Because I'm sure
There's another point I should make also, in addition to.
Please do.
Because city is talking about working capital. Yes, when you're starting a new thing, you do need to do a capital injection. But yes, it gets easier. Let me give you another example. Just in the last financial year, the total health expenditure of Kenya, public side, I'm not talking about, not total health, the public health expenditure on healthcare was 356 billion. 356 billion. Okay. On the public, that's public health expenditure. Total health expenditure in Kenya was estimated, it might have gone more, but a year ago it was 540 billion. So we are spending about 6% of GDP on healthcare. But the point I was trying to make about why we are not rational as a country, we have not been rational about healthcare. 356 billion public health expenditure. Can I tell you something? About 230 something, 200 maybe 30 something, is through national budget and donors. Of course, donors have done their thing recently and pulled up a serious hole in our budget. But there is a figure of 124 billion.
Yes.
Which interests me. This 124 billion, which is part of the public health expenditure, is spent by counties. Okay? It's county spend 124 billion.
Per year.
Per year, the last books. Our argument also as part of the reforms was that why are we duplicating functions? You know, for instance, counties buy county medical schemes. They are doing everything. You know, everything that the national government is doing, they duplicate.
Okay.
So they are spending money on their employees for healthcare. They are buying, you know, commercial insurance. In that 124B, our argument was consolidate that money, take that money away from the counties, and give that money to SHA as working capital. Let SHA provide a good medical cover for county employees. There's also money that is leaking everywhere. For example, we have the teachers. I heard you guys talking about teachers. We have the police officers. You know, there are medical schemes, civil servants. That whole pool of money for teachers, police, civil servants, etc.,
including MPs,
and all these guys, is 100 billion. Okay, we are using close to 100 billion there. Do you know that with 55 billion we can provide primary health care to all Kenyans?
Daktari Bana.
Mimi now, I'm telling you, these are government. This is estimates that we did during the transition.
You know those numbers.
The budget. The budget. What is it? The committee, the finance committee that was looking at SHA.
Yeah.
What they recommended And we were there in those discussions in Naivasha. They were very heated because, to be honest, this figure started at 750 billion.
Yeah.
To provide healthcare for all Kenyans, just walk in, walk out, according to Article 43,
yes.
highest attainable standard of care. We need 750 billion. So they gave, and I could see, because we had directors there, we had very high-ranking people there. Once the people work out the numbers, they would break out and place a call. The call goes to Nyumba Kubwa. They say, sasa, tumefika 750 billion. Hiyo ndo number. Wanaambiwa muache hiyo mchezo, go and panel beat that number. We don't have that money. We did that for 3 days. They panel beat. So finally that number came down. I kept coming down, and then it got to 275 billion. And then the experts they gave feedback back to the CS and State House. They said there is no way we can go below 275 billion. Even if you tell us to do what?
We can't.
This upper sasa, this is the end. There is nothing below. This is basic healthcare. Now, out of that, 75 billion, out of that 150 billion was meant to go to SHIF. This SHIF that we are now paying 2.75%. So 150 billion was supposed to be raised by SHIF. That leaves you with a balance of 125 billion. This 125 billion was supposed to be split between two funds: the Emergency Chronic and Critical Illness Fund and the Primary Healthcare Fund. 75B was for the Emergency Chronic and Critical Illness Fund. 50B was for primary healthcare for 50 million Kenyans. That was it. And I'm telling you that if you take the counties, and you take the police, teachers, and civil servants, you are spending double on them than what Kenya needs to provide for primary health care.
So let me take you a few sentences back. You said with 55 billion, we're able to provide healthcare for 50 million Kenyans.
Yeah.
Now, when you say
we tell Kenyans and into hospital,
hii ni kushughulikia tu the kawaida ailments or tushughulikia
that is a primary healthcare fund. So that is your everyday healthcare.
So if you have a cough, go.
A cough, chest pain, backs, you go.
You've broken.
But that's why we also had the other fund, the SHIF fund, which was supposed to take care of more expensive procedures, hospitalization. Although even the primary healthcare fund does take care of some hospitalization at level 2, but it is for minor. You might have a bout of malaria. You need to stay in hospital 2-3 days at a level 2 or level 3 rather. That's okay. But the point I'm saying. Kenyans right now are crying about outpatient care. Okay, the president says go to any healthcare facility tumelipia. Serikali ya Kenya imelipa. Nobody should ask you, walk in, walk out. What the president is not telling us is that he funded it to the tune of 13 billion this financial year against a requirement of 55 billion.
Okay.
So you have a deficit. Okay, what that then means is that the benefit package is not properly financed. So when you go to hospital, when you reach hospital, you will be co-charged. Yeah, because the unit cost of the reimbursement does not match the cost. And why doesn't reimbursement match the cost? Because the reimbursement is underfunded.
Is this in the private hospital or the public?
Everywhere.
Everywhere. Okay.
Let me understand this. And you were saying that if we added that small percentage, the 0.5 to 1%
on VAT,
yes, this would be taken care of.
We will take care of this
because everybody would pay it.
Yeah, we'll take care
irrespective of what you do, you'll end up paying it one way or the other.
Yes, we will take care of this. And one of the things we did, CT, was when the proposals came, we never opposed them. Unlike what our political people keep saying that there are cartels opposing. We never opposed, because for the longest period we were saying there is not enough money in healthcare. We need money. It's underfunded. But the 0.5 to 1% will be enough to guarantee a Kenyan to walk in and walk out of a hospital. And all we needed to do as a country, and we wrote this to the CS Nahumicha at that time. We told Nahumicha, you are rushing this transition. Okay? We want it. but you're going a little faster for the Kenyan people.
Yeah.
So we proposed a 2-year transition instead of the one they just did 1 year. In fact, even 2 years was very little for us. We even wanted a longer one, but we saw that the dynamics
SHA is
here,
actually now 2 years old.
Yeah.
But did she have the final say on this
so
matter?
maybe she didn't have. But the reason why we proposed a 2-year transition was to allow the Kenyan people to have a conversation about the healthcare system they want. Okay, we could have. By the way,
Yes.
we could have gone on with NHIF for those 2 years. It was fine. Okay, it was not perfect. It had errors and things. Just like SHA also has problems. We could have gone on, keep bandaging it, but for 2 years, we have a conversation among ourselves and say, wewe unataka healthcare inakaaje? Okay, then Kenyans would have even said, me when I want to go to hospital, I want the X-ray covered, ultrasound covered, my teeth removed, no cost, all these things. Kenyans would have said they are given their wish list.
Yeah.
And when they give their wish list, we have told them, okay, fine. See, that is what you want. This thing that you want is going to cost X for us to deliver. We have so this is your wish list. Like your children, they go to the dini and then they are picking. You tell, okay, fine, all these things you want, they don't have. This is what it costs now. You guys decide. So you have your tiny box of savings here. What do you want to buy? Okay, so we should have had a longer conversation. We told Kenyans, fine, the healthcare you want will cost 55 billion for outpatient care for a year, for primary care. Now, for us to get that, where do we get the money?
Okay, so question, Daktari, is on the same. The 0.5% VAT, right?
Yes, on VAT, for example.
Yeah, so 0.5 was going to take care of everything from the critical illness, the chronic ones, the outpatient, any kila kitu. This is the 0.5.
So we are a small economy, Mbuvi. We are not a large economy. We even if we did 1% on VAT, okay, we will not get enough money to take care of ICU and such things. And that is why also, and we agreed that a hybrid system that also has contributions would be ideal. Now, that's what do I mean? I mean that for salaried employees, we would continue with a contributory mechanism, okay, to still raise that kind of money.
Okay.
And we would also have even asked as I've said already, consolidated state funds that are being wasted into that same basket. So the idea is take a global view of healthcare and say, okay, so where are we leaking money? Where is all the money? So we are spending these teachers here, police here, counties here, all these parastatals, MPs, ambassadors, all these guys are covered. Okay, so all this, how much is it? XY billions. Who needs to be paying this? We need a sickness fund that pays this for Kenyans, isn't it? So we pull that money into that sickness fund. Then we say, okay, so if we pull it, it is not enough. Okay, because we are a small economy, we are not Belgium, so the Belgians, for example, are spending, and by the way, they are spending about 10% of GDP on healthcare. Us guys are doing 6% in a poorer economy. You see where the extent of our problems. Them with 10%, they provide 99% coverage for all citizens. But when you go down, what you find out is that they are looking at income. So salaried people are paying differently, all this, and taxation is in the mix. You just collect money. But you ask yourself,
and then they don't have as much corruption as we do. But anyway,
continue. and then by the even the reason why it's been very saddening is, do you know, at some point from 2021 around there, after COVID and up to the time when we had the reform, there were Kenyan experts who were paid on our expense and traveled around the world to study health systems.
To benchmark.
Yeah. And these guys went to Thailand, these guys went to Japan, these guys went to Belgium. They went everywhere. And they came back, they knew everything.
And they brought us SHA.
Yeah. That's your situation, man.
So what we are saying is that we could have continued with NHIF, right?
In fact, let me tell you something interesting about NHIF, which is always lost in the sound bites. Okay, there is one of the arguments that why SHA is so good is that now you have 3 funds and Parliament can now appropriate money, can put money in SHA,
Yeah.
unlike under NHIF, where Parliament could not put money, isn't it? That's a very funny argument.
Yeah.
If you look at the NHIF Act, in fact, that is clause number 6, if I recall, the means with which NHIF could collect money included donations and grants. Grants from the national government. So in essence, what I'm trying to say is that for now, Parliament pumps 13 billion this year, 13 billion into primary healthcare, and they are pumping another 10 billion into emergency chronic and critical illness fund, right? It's 23 billion. There is nothing in the NHIF Act that stopped them. Nothing whatsoever.
Okay.
They could just have woken up and pulled, okay, let's, as we reform, let's give NHIF 23 billion, okay, to deal with primary healthcare as we Kenyans discuss what kind of healthcare we want. Nothing.
But remember, this is now where the genie of politics comes in. And this genie is out of the bottle. Huh? You have a situation where politicians want to show those who elected them that they are doing something. And in this country, that is done by introducing new things which aren't really new. They're old things repackaged and given a coat of paint, but you are told it is new. Then a lot of language follows it, and within it you will find that there are things that actually make sense, and you say this is actually a good thing. But the problem will be it isn't well thought out. We piloted universal health, didn't we?
Yes, we did.
Did we ever internalize what it is that we found, or what we sort of like unearthed from that pilot? And the moment you introduce a pilot, you know what you're doing? You're saying, let's start with 4 counties.
And test it out.
Yes, that finding will enable us to determine what it is we need to tweak. Then you go to a larger group of counties. From 4, let's go to say 14. Okay? We still haven't hit the halfway mark. All right? Then you'll say, these 14 have given us a clear indication. And given the disparity and everything that we have, then you say, look, so that we actually conclusively figure out what it is, let's now look at, say, 30 counties. Okay. We've gone beyond the halfway mark. We'll have a fairly clear idea of what works and what doesn't work. So when you're implementing, there's no hit and miss. Whatever tweaking is required is just internal, but by and large, you know.
And the other beautiful thing about piloting is that once you pilot, it gets cheaper as you go.
Yes.
Because now you don't need to create the same infrastructure over again. You don't need to do the same mistakes you've made. So every next 5 counties is much cheaper.
And everything about it is better than the previous ones.
Yeah. So I just, okay. So one of the things that we have been accused of as private hospitals is pouring cold water on SHA and, just saying everything is doom and gloom. But
have you been pouring cold water?
No, we haven't. We have actually. That's according to Duane. But we haven't. What we have been saying is that there is hope for fixing if there is a goodwill to fix it. Now, let me explain a simple problem we have now. We issued a notice on 5th of September. We said, okay, we will do a go slow. And we wrote to the CS, we wrote to the CEO, we told them these are our concerns.
When you say go slow, kindly tell us.
I will elaborate.
Yeah.
So, there are different forms of industrial action.
Yes.
So, so for us in healthcare, we could see like a termination of services or seizure of providing services is one. A go slow in this case is that we are not extending 100% credit to SHA.
Okay.
We are doing on a needs basis.
Okay.
So in other words, hospitals decided to take a very humane approach to this issue. We understand the economic situations that Kenyans are facing. There's a lot of patient hardship out there. We deal with them every day. So it was very clear from our membership that 100% seizure of the services would punish Kenyans, and we need public support for the reforms that we are asking for. In other words, we don't want to turn the public against the providers, because then our message will be lost in the, the emotion of service, being. So what we did essentially is, as providers, agreed that on a case-by-case basis, we will determine when to charge and when not to charge. So this is why, it's a fact, this is why anywhere you walk in this country, there is nothing like free outpatient. It doesn't exist. If a very distressed patient comes to hospital, they might walk in and walk out. But for common ailments, for your day-to-day issues, the likelihood that you will pay extra to your cover is close to 100%. So we are co-charging. So there's a lot of co-charging happening. There are patients who are going back to pocket. It is happening. This is not ideal. The ideal scenario would be that the promise of the law is maintained. For example, the promise of the reform, rather. If it is free outpatient services, as I've said, there's a gap between reimbursement and cost of care. What we are trying to push is for that gap to close. And it's not even private hospitals alone. Public hospitals are co-charging. And nobody is talking about public hospitals co-charging because they are very good at doing it silently. They are very good at doing it. In fact, if anyone has invented very good ways of co-charging, it's public hospitals. They don't even ask you for money. They just tell you gloves hakuna. Cotton hakuna.
Gloves. Come back with your own notebook.
Kuja na notebook yako.
Come with a bottle your own bottle that we can give you the cough syrup you want.
Kuja na chupa yako tukuwekee dawa. Hii unaosha na
pale ufotokopiwe karatasi ya kitu fulani.
All these are co-charges. They are co-charging all this. Syringes, unajua enda nunua pale. They are co-charging for lab services. Is no public hospital that is offering free lab services. So this is happening. So that's the difference. The difference was we instructed our members that it is no longer sustainable to provide 100% credit to the Social Health Authority. Why did we get there? We got there because, one, SHA inherited NHIF liabilities. Okay, I want to correct this because our government colleagues have been, every time they stand up, they say, let us differentiate SHA from NHIF. These are two different things. I mean, this is a blatant lie. There is nothing like NHIF liabilities. Immediately SHA took over, the liabilities became SHA liabilities. So they are their liabilities. This 33 billion shillings is causing severe distress, severe extreme distress. The government started making excuses that somebody went to court to stop verification. When you lift the veil on that suit, the person who went to court is a doctor in the public sector. Is a public sector doctor who works for a county who went to court. It's not even, private hospitals didn't go to court. We never had an issue with verification. Said proceed. Now, obviously, the courts ruled and they told the cabinet secretary, the only problem we have with your verification team is that it is external to SHA. This is a problem. Two problems. One, it is external to SHA. What is the problem of that? You are exposing confidential patient information to non-contracted parties. These parties are not, the people you are showing these medical records to are not party of the contract between the provider and the Social Health Authority. Therefore, they have no permission to look at people's healthcare records. So they said the team being extra SHA is the first problem. The second is that if you are going to audit the use of public resources, you must involve the Office of the Auditor General. Simple. There is no representation of the Auditor General in the committee that you have made. Therefore, on this basis, your committee is unconstitutional. So nothing is stopping the cabinet secretary from just simply taking the ruling of the court and implementing it according to what the court has instructed.
Nothing
is stopping me. He goes to SHA and he creates a team within SHA and he says, you guys are the verification team, isn't it? And then he writes to the Auditor General and says, please second as a representative to the verification committee. And he does it. By the way, let me tell you guys, we have said this repeatedly, this 33 billion, it is shocking. 15.2 billion out of that 33 billion, that is 50% of the debt, is owed to only 83 hospitals.
Repeat that again.
15.2 billion
out of 33.
That's about 50% of the debt is owed to 82 healthcare facilities. The total number of healthcare facilities owed by owed by SHA historical debts is 3,700.
3,700. That's the number of hospitals.
Who still wanadai
3,000.
3,700 are are the hospitals who are owed this 30 billion, 33 billion, 3,700. But that's the level of stress.
And of this 33 billion, 15.2 billion
is to 82 hospitals.
Only hospitals.
And I have gone even further to look at that.
Some of them your members.
A few of them. A number of them are our members. But let me tell you something interesting. When you hear statements, and this is part of the reason why we went on go slow, when the cabinet secretary and the president said that NHIF debts are fictitious, okay, they are fictitious, they are proceeds of graft. First of all, what they are setting us up for, non-payment, because it's illegal for a government officer to pay proceeds of corruption. Once you label these as proceeds of corruption and fictitious, it's the same as the counter. It's just the same as saying we are not going to pay because we can't pay for graft.
So essentially, I mean, if one were to take whatever has been said literally, you're saying that all these 33 billion things are a sheer fabrication.
They are lies.
How exactly can that be a possibility?
It's not possible. Susan Nahumicha, the former cabinet secretary, gazetted a transition committee in February of 2024. She gazetted a committee chaired by Jack Kipkorwak. That committee had about 16 members. It was a very good committee. That committee finished the audit of NHIF and they handed over a report. That report, in that same report, by the way, this figure of 33 billion is not snatched by off the air. Somebody went and just picked a figure and said,
what figure?
What a good figure we can owe.
So we have about 20 seconds, before we
So Nahumicha's team, the transition committee, which was her team, is the one that came up with the figure of 33 billion. It is in the report. And they signed off against the report. In fact, they even go as far as saying there are 2.7 million unpaid claims that we are handing over from NHIF, and we have verified these claims. So it didn't come from the air.
It actually came from the government. And now the government is saying fictitious.
Now, even worse, 10% of that 30 billion is owed by two government hospitals, KNH and MTRH.
Daktari, clearly we need more time. I don't know how your next week is like, but clearly we need more time.
With this kind of coffee, I might come.
Karibu sana. That is Dr. Brian Lishenga. He's the chairperson of Rural and Urban Private Hospitals Association of Kenya.